Hello, everyone, and welcome to today's MinMD Real Talk webinar, If ED Pills Fail, Injections to Implants. My name is Austin Hunt, and I'll be your moderator for this event. I work on the marketing team here at MinMD, and I'm excited to be hosting this session today. Before we get started, we have a short disclaimer that we need to review.
The health and medical information provided during this webinar, as well as the questions and responses from the webinar providers, are solely for informational purposes. This content is not intended to take the place of advice or treatment from health professionals. Nothing presented in the webinar is intended to be used for medical evaluation, diagnosis, or treatment. It is not intended to substitute for your relationships with your own healthcare and pharmaceutical providers. Always seek the advice of your healthcare provider before beginning any new treatment, or if you have questions regarding a medical condition.
All right, with that being noted, I'm pleased to introduce today's presenter, Dr. Shawn Blick. Dr. Blick is a fellowship-trained urologist who specializes in erectile dysfunction, penile implants, male incontinence, low testosterone, Peyronie's disease, enlarged prostate, and prostate cancer, and is located in Phoenix, Arizona. Today is going to cover the underlying causes of ED, medical treatment options beyond pills, surgical treatment options, conduct a short demo, and then hold a live Q&A to close out the webinar. So without any further ado, I'd like to kick things off by welcoming our presenter, Dr. Blick. Over to you.
Hi, everybody. Appreciate you taking some time out of your schedule to join me to learn a little bit more about erectile dysfunction. It's definitely a passion for me in my work. I just want to say a special thanks, though, to Boston Scientific and MinMD for essentially co-sponsoring this event and making this come to fruition. If you're experiencing some bad weather out there in the United States, my prayers go out to you, and even more so if you know anyone in the Ukraine or having any relationship to this whatsoever, my heart and prayers go out to you as well. A little bit about me: I'm just the president and founder of a group called Valley Urologic Associates in Phoenix, Arizona, and I've taken my subspecialty into the area of men's health. I created something called ED Specialists of Arizona, a center of excellence for men's health and penile implant surgery. And so I specialize in things like you just saw that are listed: ED, penile implants for ED, male incontinence, which is another version or another technical implant that cures ED, low testosterone, Peyronie's, enlarged prostates, or some people call it BPH, and prostate cancer. So we start off with just saying erectile dysfunction. What is it? Who has it? And what causes it? Let's address that. Next slide. So what is ED? Simple. The persistent inability to achieve and or maintain an erection satisfactory for intercourse. And I like to point out two things in this slide. One is that there's a spectrum of disorder. We have people out there who have absolutely no erection at all, no matter what they do. We have people with partial erections. They score lower on the rigidity scale. Then we have some people who get really great erections, but they don't maintain them. They lose them before their desired result has been obtained. And so there's an obvious spectrum of disorder out there. And the other main point on this slide is it's extremely common, very ubiquitous. 1 in 5 American men greater than 20 years old experience ED in their lifetime. Greater than 50% or more than half of men over the age of 40 have some degree of ED. And somewhere in the order, this is based on the Massachusetts Aging Study, somewhere in the order of 39 million American males may experience moderate to severe ED at some point in their lifetime. And so it's a really highly prevalent thing. You're not alone. As men age, we seem to acquire this dysfunction. Next slide. So a little bit about causes and conditions associated. This is what I call the ED pie. As you can see from the slide, the majority is cardiovascular, which really means blood flow issues, heart issues, blood vessel issues. And the other large portion of this pie is diabetes, another 30%. And when we talk about diabetes, it's actually a very multifactorial etiology. Diabetics, unfortunately, have everything from blood flow problems to potential for neurologic problems to even hormonal problems, and they often coexist and make them much more difficult to treat. They have disease that may be more refractory to other therapies. Medication counts for 15%. Just to review some, I mean, any major tranquilizer, antidepressant, any kind of chronic pain medicine, blood pressure medicine, particularly beta blockers, but calcium channel blockers, ACE inhibitors even are all potential causes for ED. So it's really important that we look at your medication list, and sometimes we can adjust medications to make things better. Smaller in the pie, believe it or not, is prostate surgery or pelvic surgery. We're referring to men, particularly that have had prostatectomies for their prostate cancer. They often also have a very difficult disease entity to treat and are often more refractory to therapy. Interestingly, as you go down the line, and I think this is a key point on this slide, endocrine. Endocrine means hormones, and as you might imagine, this is where testosterone lives. So testosterone is only 3% of the ED pie, and that is often surprising to most of the attendees, because often when I get referrals, people are asking me to fix their T with the thought that for sure that's going to get rid of the problem. But testosterone often more relates to sexual drive. It definitely does have importance for sexual health and for normal erections, but it is a much lower cause, meaning that if I replace your testosterone, most of the men that I replace don't actually improve because the majority of the issues are cardiovascular, diabetic, and others. So please respect that thought. It's an interesting eye opener for a lot of attendees. Next slide. So the erection process, I'm going to teach you a little bit about how a normal erection occurs, and the reason why we do this is because then if you understand how a normal erection ensues, then you understand where all the disease entities or all the where things can go wrong. So in order for a normal erection to occur, you actually have to have normal nerves. The nerves essentially allow the arteries or what's red on that screen to relax and then fill the spongy tissue within the cavern, the cavern of your penis. So normal nerves must relax normal arteries to allow for the spongy tissue of the penis to expand. And then in order for it to maintain turgidity or rigidity, you have to have normal veins. The veins have got to be able to collapse and push against the tunic of these channels in order to keep the blood in place and create good rigidity. If there's a problem with nerves, if there's a problem with the arteries, if there's a problem with the smooth muscle of either the arteries or those sinusoidal spaces or caverns where the blood normally fills, or the veins are somehow not collapsing properly and they're not holding blood, we have therein lie have the problems with erectile dysfunction. Next slide. So how do ED medications work? I mean, all the ED medications do one simple thing. They simply promote better blood flow. And they do that in a structure called the corpora cavernosum, which is the main, there are two of those structures running within the shaft of your penis, as you may have seen in the other slide. And essentially that's what allows for a normal erection. And there's also, just to say it in this slide as well, the urethra has its own spongy tissue, and the urethra is on the bottom side. It's below the corpora cavernosa and eventually becomes the head of the penis. So that also fills with blood and helps form the normal erection. But simple, ED medications promote better blood flow. That's what they do. Next slide. So let's move into a little bit about the treatment options. And I put this slide up there. This is a relatively comprehensive view of the different treatment options that we have. There are some others that are out there, but this is the mainstream. This is what's mainstream medical therapy that most urologists or other physicians in the community will offer. And one thing I like to do, I just want to just review them briefly before we go into each and every one of them separately. There's oral medications. Those are the Viagras and the Cialis of the world. There's something that you may not have heard of called intraurethral gel, or needleless insertion of a gel into the urethra of the penis. There's something called injections, where we inject vasoactive agents straight into the corpora cavernosa, that structure that I just pointed out to you. There's vacuum device therapy that pulls blood into your penis and allows us to trap it with a special ring. They call those vacuum erection devices. And there are penile implants, implants that go inside. They're minimally invasive surgical procedures that allow for an erection that you essentially pump up internally. But in the old days, we used to look at this as a continuum. You'd go from oral meds to gels to vacuum. You have sort of a stepward process. And a really important point I'd like to make here is the American Urologic Association, the organization that I'm boarded under, has changed that whole paradigm. That it's no longer sort of this stepward process. It's actually more of a shared decision-making process between me or a physician and a patient. And and it allows me to use any treatment option at any point in your care without really feeling like we fell out of the protocol, for example. So there are people who might find that penile implants are perfect for them at their stage of their disease entity or what they're going through. There may be people who injection therapies are perfect for them right out of the gates. Most urologists start with oral medications just because of how simple they are to take and that they're, you know, the least invasive. But it is a definitively shared decision-making process based on your values, preferences, and certainly the current status of your disease entity based on how we can help suit you with a particular you know, treatment choice. So with that said, let's just go further into the different treatment options. So who can treat erectile dysfunction? Pretty much all the different kinds of doctors out there in the field can. General practice family doctors are well suited to have a general understanding of ED, and they can prescribe medical treatment options. The urologist is probably a little bit more specialized because that's their area of expertise, and they do a little bit more training in the physiology of the male reproductive organs, for example. And more particularly, I think this is an opportunity to distinguish myself. There's something called prosthetic urologists, or what we call sometimes an ED specialist. And really, that's just a urologist that has taken special attention to the field of men's sexual health and men's health in particular. And we particularly specialize in a technique called penile implants that other urologists and or family doctors just don't have the skill or ability to offer. Prosthetic urologists tend to be a lot more comprehensive in their approach. They tend to be a little bit more goal-oriented rather than they tend to be more cause-oriented rather than goal-oriented, a little bit referring to what I told you about before. So we're much more cause-oriented. We have a lot more techniques to diagnose what's going on with your issues. And we certainly have a larger arsenal of options to offer to patients to treat. So with that said, next slide. So oral medications, there's a little few letters on the top there called PDE5I. That stands for phosphodiesterase type 5 inhibitors. That's what they are. They're phosphodiesterase inhibitors, and these include the pills like Viagra and Cialis, which we're going to talk about right now. So they're not most important point about some of these conservative options is they're not 100% spontaneous. They're not always 100% reliable, and they often do have ongoing side effects and costs. However, people do start with pills as first-line therapy for their simplicity. They're maybe only about 70% effective across all comers. To the people if we line up all the people that take them, only 70% will respond. They require sexual stimulation. That's really important. These pills potentiate blood flow. So if you take a pill, they don't actually cause blood flow right out of the gate. It's different than, let's say, an injection or the gel that we might put into the urethra that is directly vasoactive. This is potentiating blood flow into the proper spaces, and so you have to have sexual stimulation. And what's interesting is that means you also have to have intact nerves. The nerves must be able to relax those blood vessels in order for these medicines to potentiate. So these two, for example, sildenafil and tadalafil, they're very similar. They're both phosphodiesterase inhibitors. They come in different doses, but they have uniquely different half-lives. Cialis or tadalafil has a 36-hour life to it because it has a much longer half-life. And so, for example, you can take the pill on a Friday night. It'll work for you that night. It'll work for you the next morning. It'll even work for you the next night, all in the same pill because of its longer half-life. Sildenafil, or what's known as Viagra, is a shorter half-life, and it only has about a 4 to 6 hour window for it to work. Most of these pills work quickly. If you take the pill within a half hour to an hour before intercourse, they often work well, but that's on an empty stomach. Most of these pills are food dependent, and so therefore you do need more time to allow for them to absorb if you're on food. So if you were going out to dinner and you're using sildenafil, not just a half hour to an hour before intercourse, but maybe an hour and a half to 2 hours of time to allow for normal levels to be in your blood for these pills to work. Tadalafil is less food dependent because of its long half-life. Interestingly, there are other medicines besides these, they're just not on the screen, but for example, something like mental block, something like Levitra for example, is another particular pill, is very food dependent, and you'd have to be careful about the food dependent. So you get an idea that there are some pills that are very food dependent, some that are not. Very important to know the proper relationship in order to get the best success. What's important about these meds is that if you're on nitroglycerin for a heart condition, you do not want to take these at the same time. And the reason is that you can drop your blood pressure and get very low blood pressure and tank. So you don't want to do that. So you do not take phosphodiesterase inhibitors with nitrate medicines. And another key one is alpha blockers. A lot of men who have enlarged prostates take alpha blockers to help them pee better. An alpha blocker, something like Flomax or Flomax, you might consider like Cardura or Hytrin. Some people know Uroxetrol, some people know Rapaflo. There's a whole variety of these medicines, and they can interact with these medicines and cause low blood pressure. So not to fear, if you're on these medicines, I still think it's okay to take it. I think you can take your alpha blocker in the morning with breakfast, for example, and use your pills for ED at night so that they're separated and they're not falling right on top of each other. And I found that to be actually very safe. Certainly, if you've got a history of low blood pressure or uncontrolled hypertension, those are other reasons to potentially not use these pills. Side effects are one of the most common reasons for me to discontinue these medications. They include things like facial flushing, nasal congestion, blurred vision, headaches, heartburn, back pain, and muscle pain. There's a whole variety of them. But oftentimes I get the headache complaint. That's really the biggest. People get feel like their head's going to explode. But for the most part, they're very well tolerated. They're generally very safe. They're usually first-line therapy, and that gives you a little bit of a background about these pills. Next slide. So there's a lot on this slide. Why do some men fail oral meds? Well, I kind of gave you the idea that oral meds potentiate blood flow. So anything that sort of enhances the severity of the blood flow issue or possibly knocks it out altogether because of nerves, you don't have good nerves, will make it harder for the pills to work. As I mentioned to you earlier, diabetics have a very multifactorial etiology with blood flow problems as well as hormonal problems as well as neurologic problems, and it tends to be very complex and they tend not to respond as well. Certainly if you've got coronary artery disease or heart disease, we see arterial buildup of plaque over time systemically through your entire body, and this can reduce blood flow and can get to a point where pills just cannot overcome it. High blood pressure can also thicken the arteries as well and reduce blood flow, and maybe increased alcohol and recreational drug use can have some effects, but it just gives you an idea that anything that exacerbates the situation can sometimes make the blood flow problem worse or affect the nerves that can have an impact. Prostate cancer treatment or ED severity relates to the fact that when people have prostate cancer, they undergo surgery or radiation, and these are very difficult patients to treat because of the fact that it affects their arteries and their nerves and maybe even their veins. And so it's a very multifactorial etiology, and they tend to be very refractory to therapy. Also on this slide, just for your information, just shows you the relative size of the different blood vessels as they compare to each other. So the penile artery at the top, where it says erectile dysfunction, is only 1 to 2 millimeters in size, whereas, like, for example, a carotid artery or leg or femoral artery is much, much larger and takes a lot longer for these to obstruct. So a 50% obstruction can occur much easier in a smaller artery like a penile artery than it might in, let's say, your heart or other areas. This also lends me to bring you to a topic in this slide that there's such a thing as called ED and the cardiovascular connection. When people present with ED, it may be the first presenting sign that you actually have heart disease because it's a systemic disorder. The first arteries that go are the smallest, the penile arteries, and they may just be the first sign that one day you could develop heart disease. So it's really important to make the ED and the cardiovascular connection. And if you haven't and you've never seen a cardiologist or had anybody do an EKG or stress test, it's probably worth at least entering the system and having it checked out. And the last point on this slide is that certainly men who fail oral therapies usually respond really well to injection therapies. Injection therapy happens to be a very highly successful therapy that we're going to get into significantly during this talk. But I just want to make that point that when oral meds fail, people often flip into trying injection therapies And again, it doesn't have to be stepwards, as I told you. People can try injections up front just as well as they can try pills up front, just as well as they can do penile implants up front. Next slide. So the next modality to talk about is the intraurethral gel. It's basically taking the vasoactive agents that we use for injections and essentially compounding it and making it into a formulation that you can just inject into the urethra. They have 1 and 2 drug gels available. Typically, we're dealing with L-prostadil, which is also known as prostaglandin E1, and phentolamine is another vasoactive agent. It gets injected into the penis, it gets absorbed and facilitates that blood flow directly. As opposed to the phosphodiesterase inhibitors, which only potentiate blood flow. This happens whether you like it or not. It's going to occur. It's an automatic response. You could be reading a magazine and you're going to get an erection. So it happens directly due to the vasoactive properties of these drugs. The onset of action is pretty quick, within 5 to 15 minutes. It's certainly more effective than oral medications, but probably less effective than the direct injection into the penis itself. And in the clinical literature, we see success rates up at 65%, which is pretty good, but certainly not 100%. There are definitely patients that don't respond well to these modalities. And one of the most common side effects is the urethral pain or burning with application. Certainly you might expect if you inject something into the urethra, you might get an irritation. And certainly anytime you use vasoactive agents, there's the risk for something called priapism or an erection that just won't go away. Initially, that sounds like an awesome thing, but it is long-term extremely painful and potentially deleterious thing to have happen to your penis. If an erection stays for longer than 4 to 6 hours, what starts to happen is there's very low oxygen within those sinusoidal spaces or the sponge of the penis. And so what ends up happening is the tissues die and then it become very fibrosed or scarred, and then it becomes almost impossible to have a normal erection in the future. So we never want to have anyone have priapism or erection that lasts more than 4 to 6 hours for this very reason. And so we try to give upfront education so that if you're having an erection that might not go away, that you know to seek attention much earlier. Don't go to the ER at the 6th hour, because you're not going to get treatment until the 12th hour or maybe more. And so then you're going to have unfortunate side effects. And so we ultimately want to prevent that and give you really good upfront education. Another thought on this slide is that storage, partially used or full syringes should be refrigerated. That's an important point because not all people have a refrigerator in their bedroom. So sometimes that means a moment of intimacy must be stopped in order to get these medicines or prepare so that they're in reach so that you can get them when you're ready. Next slide. So the vacuum device is an interesting tool. It's exactly what it sounds like. I'm just going to, in this particular picture, I'm just going to point out that there's essentially a vacuum sucking part of this, which you see at the top of the picture, followed by a long plastic cylinder, which essentially fits over your penis. So if you can do this either manually or you can certainly do this with electrical, but essentially it pulls blood into your penis and creates a vacuum as you put your penis over it. And then essentially you put a constriction ring that is sort of set at the end of the cylinder. And then once you put your penis inside it, you can flip the ring onto the end at the base of your penis. And I'm going to demonstrate that later, or do not my own, but I'm going to show you a little bit of the product and I'll actually show you the actual elements of the vacuum device. So I mentioned once again that there's manual modes, there's battery operated modes. Essentially, elastic tension ring is placed over the base of the penis to maintain the erection once the vacuum pulls the erection. It's only about 68 to 80% satisfaction for a variety of reasons, just because it is a little bit clumsy. It does slow down the spontaneity of the intimacy that you might be having. It can block the ejaculation due to the restriction of the constriction ring. You should only use this for about a half hour at a time because, again, you're essentially stopping the blood flow and trapping it within your penis, so the blood eventually becomes low oxygen tension, and it's a little bit it's not as natural as like a normal erection where there's actually at least some blood flow moving. And so it can cause penile numbness, it can cause some bruising potentially if you're not careful, and certainly discomfort if left too long. Once again, I don't recommend utilizing this for longer than a half hour at a time, just to prevent tissue damage inside the penis from low oxygen. Next slide. So this picture really does a nice job of demonstrating what I was talking to you about. It shows how the vacuum device portion of it, this is the manual version where he's using his hand to pump it manually. But what we're talking about in this slide is vacuum device for penile rehabilitation. What is meant by that? We have patients that, for example, undergo radiation for their prostate cancer or surgery for their prostate cancer. And unfortunately, they have very difficult ED to treat. And in some cases, depending on the nature of their surgery, if they've had nerve sparing surgery, for example, or the nature of their radiation, they may be able to rehabilitate or recover spontaneous erectile function over time. And using a vacuum device can enhance that. So we call it penile rehabilitation in an attempt to revive normal spontaneous erections again. And so what happens is you basically don't need the constriction ring in this case. All you need to do is put it over the penis, pull the blood into the penis, and then essentially maintain it, you know, somewhere on the order of 20 to 30 minutes at a time, several times a week, in a regular pattern over time will actually maybe enhance the success of spontaneous recovery of erectile dysfunction after, let's say, radical pelvic surgery. Other people can utilize this to help maintain penile length. As men develop ED over many years, many of you may have experienced this, there's a certain loss of length due to the lack of or loss of elasticity within the smooth muscle of the penis or the smooth muscle of the sinusoidal tissue that fill the caverns. And so people sometimes lose a little length over time. Again, vacuum device therapy pulls oxygenated blood and revitalizes the tissues inside and can sometimes maintain penile length or enhance it. And especially after prostatectomy and radiation, and certainly for men that have lost their nocturnal erections, men who are just starting to develop ED, who've noticed for a long time they don't get these nighttime erections, this may promote better blood flow into their penis and assist in some of the other modalities that we're utilizing in an attempt to make a better success. So we can utilize penile rehabilitation in multiple avenues, arenas, if you would, and can be successful in some cases. Next slide. So intracavernosal injection therapy, as I mentioned, men who don't respond well to pills can often go to injection therapy. And this may be one of our most successful conservative options that we have. As you can see from the picture, it's just a picture of a syringe with a needle that we inject directly into the penis with vasoactive agents that facilitate an erection, and it's a very high success rate. What you can see on this slide is there's many different formulations. The majority of the clinicians in urology are using something called a trimix, and there are 3 agents that I can mention to you that are in trimix. There's one is called alprazolam, or also known as prostaglandin E1. Papaverin is another agent, phentolamine is another, and when we put them all together, they synergize and make the best long-term result, and they come in a multitude of formulations. And what we sometimes find is that some patients develop an achy sensation in their penis, maybe 20% of the time. And if that's the case, we realize that it's actually most likely coming from the alprazolam or the prostaglandin E1. And we have 2 ways of handling that. One is we can use a bimix and drop off the alprazolam portion of it. We have a whole bunch of formulations for bimix, or we can try low concentrations of the prostaglandin E1 and drop that off and work with the trimix solution, but just decreasing the dose of the alprazolam. So we have some different ways of managing this for different kinds of patients. Next slide. As you can see from this slide, this just gives you a little bit better understanding of what we're working with, because not everyone's seen a needle and understands how to work with them, and that can be scary. But when we're done today, hopefully I'll acquaint you with these things and get you well suited to utilize this modality if this is your interest. First point of this is that needles come in different sizes. We tend to choose the lowest gauge or thickness of the needle. So this is, in this picture, you're looking at really like a 30 gauge needle. It's extremely small, so it doesn't hurt to inject. And the length, you know, obviously we want to pick a length that's average for that works for the average person's penis size, so that when we're injecting essentially all the way in, that it doesn't necessarily go through the other side, for example, that you can reliably inject it and get it into the right space without too much thinking. Obviously, there's a plunger part, there's the stopper part, there's the needle. As far as volumetric measurements, I think it's helpful just to measure, to give you some idea, to teach you about the dosing and the measurements. So, for example, in this, it's one really important point is that a milliliter is the same thing as a cubic centimeter. So oftentimes when we say 0.3 milliliters, that's the same thing as 0.3 cc's, which is the same thing as 30 units on these. These are sort of like diabetic needles or tuberculin needles, and they work with units. So, you know, here you can see 10, 20, 30 units. It's all the same. So really mostly we're talking about I usually like to talk the volume. So I usually tell people 0.3 cc's or 0.3 milliliters to get them an idea of how much volume we're injecting so you know what to do. Next slide. So we, as clinicians, need to start out with a dose that seems appropriate for your particular disease state. And we'll essentially start off with an average dose, you know, usually on the lower side because we don't want to cause priapism. And essentially we're using this log, you know, to check your progress. And we're saying, well, mark the date, look at how much we recommended for your first injection. I often start off with something like 0.1 cc's, for example. And I might use like a 10-1-30 formulation to start, for example. And then what we would be doing is looking at your rigidity scale, and we just need to ask you to kind of grade your rigidity. So if you're in the 7 to 9 range, that's ideal. But you know, we certainly want you to be so maximally rigid that you're going to develop the priapism that we talked about earlier. And certainly if the erection does not come down in a normal amount of time, you know, we usually like the erection to probably last again. You don't want, let me say it this way, you don't want an erection to last more than 4 to 6 hours. So I tell people if they're getting an erection for as long as 2 hours and they can't get rid of it with normal sex and ejaculation and maybe a cold shower, they need to start dealing with the fact that they may have priapism and make a move to either your physician's office or to an emergency room or even an urgent care. But a full erection that does not come down requires a reversal medication. It means the dosing is too high. We do have reversal medication, so it's possible to prescribe that at the same time we prescribe your injection. So please understand that you don't have to go to emergency room. We can actually prescribe you the reversal medication if necessary. So people who are extra sensitive, we can always accommodate that need. And it's certainly a partial erection not rigid enough for the entirety of penile or for penetrative sex means the dosing may be too low and we may need to increase the dose. A couple of important notes, do not exceed the maximum prescribed dose without consulting us because these things can cause low blood pressure, they can cause priapism and or scarring and other things, so we really want to have control over it. We do not recommend injecting more than once in a 24-hour period, mainly because we don't want to have priapism happen, and most doctors recommend no more than 3 to 4 times weekly to minimize scar tissue because you'll be injecting into your penis side to side over time, and over time, to be fair to you, this modality starts off working awesome, and then slowly you may notice that at your given volume that you need to increase the volume at your dose, and then you may notice that that stops slowly working, and then we need to increase the concentration at a lower volume and then grow that volume up. And we can keep doing that for a very long time. But as you can imagine, over many years, it's possible to develop scar tissue and eventually get to a place where the injections just don't work anymore. And that's a pretty common pathway that we often see in both practice. But people use this modality really successfully and have really great results with it and like it. Next slide. So a little bit about just how to prepare it. Not everyone, again, is familiar with this. Essentially, I'm going to show you more towards the end of the talk how this needle looks and how we work it. Unfortunately, I only have one hand today because I had a ski injury, so I'm doing all with one hand, but I'll do my best just to show you basically what's going on. In the simplest terms, what happens here is you draw back on the syringe to the, let's say, to the dose that you need. Let's say here they're using 20 units or 0.2 cc's. You draw it back, an empty syringe, and then you put the needle in with the canister or the vial of your medicine upside down. What happens is you inject that air in, and what happens then, it makes it really easy for us to pull back. It almost wants to come back forcefully all on its own. And so then you draw back until it gets to your desired dose. So you have an empty syringe of 0.2, you inject that air in, boom, out comes the fluid forcefully right back at you, tap the end of the needle to get rid of any bubbles, and then you pull it out. Now it's ready for you. Then all that really has to happen, and I'll show you in another slide, is that you'll essentially wipe your penis with an alcohol pad, find an area where there's not a blood vessel, and you'll inject. and within 10 to 15 minutes, you'll have a solid erection, especially if you're having sexual stimulation. Next slide. So this is a little bit on the education about how to actually do an injection. A couple of key points here. The corpora cavernosa, or this dark brownish sort of area, it's really red, is the area where we're shooting for. Those are the caverns that fill with blood when you have a normal erection, as we've taught you. And what we're looking for is to inject somewhere at the 1 and 3. I'm sorry, from the 1 to 3 o'clock. Let's just say it this way. Let me say it differently. You want to look at the 3 o'clock and the 9 o'clock. Those are the two places on the clock that you can go to, and you can go as high as the 11 or the 1. So you can go up as high as 1 to 3 o'clock, or let's just say 9 to 11 o'clock, depending on which side you're on. And so looking from the top of the penis down, you never want to inject right on the top because there are nerves and arteries and veins right there. And at the very, very bottom, at sort of the 6 o'clock position in this diagram, there's the whole urethra. So avoid the 12 o'clock position, avoid the 6 o'clock position because there are nerves, arteries, and veins, and urethra. And you want to look from the 9 o'clock on your on the left side of the screen, and you want to look at the 3 o'clock position on the right side of the screen, and you don't want to go higher than the 1 or the 11. And that gives you a rough frame of where you're injecting. It's not hard to find that. Just pick a spot somewhere about an inch off the base of your penis. Again, just drop off a little bit lateral away from the midline, and probably anywhere you inject there will be just fine. Most important, you want to make sure the area is free of veins. You want to gently press the plunger and then ultimately inject the medicine. Remove the needle, and then once you remove the needle, just apply some mild pressure to the area for just a few seconds. The needle's so small, there's very little back bleeding ever, and then that's it. You're on your way. The most common side effects of this modality, again, is the priapism that we mentioned, or prolonged erection. Certainly over many years, penile fibrosis or scar tissue can occur. If you were to hit a small vein, it's not the end of the world. You might get a small hematoma. Occasionally, there'll be some pain after the injection, and we can adjust your formulation to accommodate that. Rare. I've been in practice for 22 years. I've yet to see a local infection from one of these. And certainly what they're meaning by curvature in this area is that if you develop scarring within the tunic of the penis could get curved. People call that Peyronie's disease or Peyronie's disorder, and it could develop over many years potentially. But most don't. It's such a small needle and so easy to do that it's not an issue. Next slide. So a little bit more about the intracavernosal injection therapy. Again, I think we've covered it. Use the proper injection technique. The first dose is often taught in the office just to make sure we know what you're doing. We'll go through it with you, so make sure you feel comfortable. Obviously, see a urologist in the setting, initial medication strength and dose. We want to figure out what's the best way to start for you. Rotate the injection site within the target areas of the penis so that we don't get as much scarring. Never use more than once in 24 hours, as previously mentioned. Important to say that, hey, if it's punctured or, just to say that punctured or sealed vials must be refrigerated. It's another important point because, again, not everyone keeps a refrigerator in their bedroom, so this sometimes requires just a touch of planning. Beyond the use date, the Bimix and the Trimix multi-use vials are safe to use up to 20 days after the first puncture. So it gives you an idea you have a good amount of time to utilize all the medicine in your vial. Okay, next. So now we're going to move into talking about penile implants. This is a passion for me. It's what I do a lot of. I sort of have a national reputation in this area for doing penile implants. So I have a good skill in this area, and I love to share this with people because not everyone knows much about it. There's a lot of misinformation out there, a lack of education on this topic. So I find it's very, very rewarding for me to get out there and teach about it. But I find that I can just use this one slide to teach you a lot. There are different kinds of penile implants, first of all. And but before I say that, I just want to say something about penile implants. Penile implants, when I told you about that first slide with all the modalities, and you saw all the different modalities on there, and I kind of mentioned that we can really choose whichever modality we want, up front. We don't really have to go in a stepwards fashion, although we do pills as first-line therapy. But I guess what I wanted to try to point out to you is that penile implants are completely spontaneous in the way they work. They're virtually 100% reliable, and they ultimately have no ongoing side effects and costs once they're done, and insurance often does cover these procedures. So it just gives you an idea that in terms of statistics, in terms of actual the way things work out practically, this actually becomes the single best long-term treatment option that we actually can offer statistically long-term because of the way this thing works and the way it compares to other modalities. Now, I was mentioning to you that there are different kinds of implants. For the purposes of our discussion tonight, we're going to talk about inflatable implants, and that's just because they're the most common in the United States, and they have the highest satisfaction rates, and that's what most commonly done. But there are malleable rods that don't inflate, that just stay hard all the time, and those are options. But that's a path less chosen, at least in the United States. And then there are different kinds of inflatables, but I simplify it for you just by saying, let's just talk about a 3-component penile implant. When you look at this diagram, you can see from the diagram that there's a pump in the scrotum, there's a reservoir that hides right next to the bladder behind your pubic bone, and it holds salt water, and there are these cylinders that traverse the shaft of your penis. Keep this in mind, this is all inside, it's all invisible, and it's all connected, okay? So that's how it's done. So it's a procedure. It is a minimally invasive outpatient procedure that we put in through a 1-inch opening where your pubic hair is located, and we put everything in through that. So it's all inside, all invisible, all connected. When we pump the pump, we'll create a natural looking erection that will last for as long as you want, whenever you want. And so when people hear about that, they say, wait a minute, I can have an erection, a rock solid erection for as long as I want, whenever I want. There's no time limit on it. It's not like we're a pill or an injection or whatever, where you have a time limit, and if it gets to be too long, you have priapism. Here you can have an erection that lasts for as long as you want, whenever you want. Even if you have an orgasm, you maintain that erection until you hit the little button that you might be able to see on the pump that helps release the fluid back out of the cylinders. So already when I talk to guys, that's already like a real eye opener. Like, you're kidding me. I can have an erection for as long as I want, whenever I want, even if I have 5 orgasms. Yes. And so some people kind of kid around and say, well, maybe you're sexually enhanced, or maybe kid around and say you're sexually invincible when you have a penile implant, because, you know, it just by the way it works. This does not affect sensation. This does not affect how you orgasm. This does not affect how you ejaculate. It has nothing to do with any of that. It is invisible, so no one can tell you have it, so it's very discreet. What I mean by that is it won't go off in the airport, for example, or if you're single and you have a new partner, probably a new partner couldn't tell right away, although an astute observer will figure this out. It's a very natural looking and feeling device in the way it when you pump it up, and how it looks and feels for both you and a male or female partner. So whether you're homosexual or whether you're heterosexual, it doesn't matter. It works wonderful for both sexual preferences. So I said it's natural, it's invisible, it's durable. So we talk about 90, well, in this slide it says 94% success at 7 years. I usually quote 90% success at 10 years. So it's a very durable result. And what I tell people is that if it breaks, it's not toxic, it's just salt water. We can take old ones out and put brand new ones in, so there's no issue there. And infection rates, like we putting a prosthetic into your body, is less than 1%. And I say that less than 1% because the products are antibiotic impregnated. They're coated with rifampin and minocycline that leach into the tissues over a 2-week period of time after we put the implant. So infection rates have dropped in skilled implanters like myself to less than 1% of the time. And when you put all that together, people report like in the high 90% satisfaction, just because of its spontaneity, its reliability, the lack of ongoing side effects and costs, which distinguish it from other modalities. In terms of the actual process, like in terms of how we do it, we do the procedure I mentioned to you through a small 1-inch opening where your pubic hair is. So think about your pubic hair right above your penis in the midline. We make a 1-inch opening. Through that tiny opening, we put all the components, and you go home the same day. You're completely inflated overnight. Therefore, we need to have a catheter to pee, a little drain to pick up extra fluid so you don't get swollen, and we wrap you up nice and tight. On post-op day 1 in the morning, we see you back in the office, we take it all off, and I usually like to brag because it doesn't look like we did the surgery. It just doesn't. There's very little swelling, almost no black and blue, a very modest recovery over the last 24 hours, and on we go. By the end of 1 week, 95% of men are off pain pills if they even took them, and by the end of 3 weeks, we're teaching you how to inflate and deflate the device, and you're finished in 3 weeks. The whole thing is over, done. I will tell people to take it light. for 3 weeks not to work out or do anything heavy, but people get back to work. I've done a physician that got back, actually a urologist who got back to work on day 4 and day 5, back to doing his full schedule. So it's very possible to get back to basics. I mean, if you're someone who lifts heavy work and does construction, or in some kind of an industry where you're physical, certainly you might need more time to recover. But in general, the average person is back very quickly and recovers nicely. Next slide. So this is a demonstration video. I'll animate. I mean, it's an animation, but I'll sort of narrate it. I'll narrate it for you. So as you can see, what we're going to show is a guy who has a flaccid penis. He reaches down for the pump, begins to pump it, and you can start to see the fluid moving from the reservoir into the cylinders to create a very natural looking hard erection that will last for as long as he wants, whenever he wants. And then when it's done, whenever you want to, you hit the button. The button will release the fluid back into the reservoir, and the penis becomes soft and looks as natural as it ever did. And that's the simple demonstration. There's nothing more to it than that, actually. Obviously, I can't talk about doing a surgical procedure without discussing some risks. Obviously, most people usually choose a less invasive option as a first-line therapy. Most people will at least try the pills or the injections for that matter. And if pills and injections fail, the single best long-term treatment is a penile implant. Health insurance will usually cover this, and this is going to vary based on different areas of the country. Shockingly, some, in my area in Phoenix, we have certain third-party payers that don't cover it often, like Blue Cross Blue Shield won't cover it in my community, or Cigna might not cover it in my community, but United Healthcare, Aetna, Humana, TRICARE for life, VA's system will always cover. Medicare covers. If you have Medicare and a secondary, you're completely covered. We do cash pay business a lot. There are people who just doesn't cover, and we offer a cash pay price for it. And we can certainly talk more about that at a later time. Really important here, natural and spontaneous erections are not possible after we do a penile implant. So once you've made the decision to go down this line, you can't sort of step back out of it and then go, well, I just don't want to do that now, because you won't have natural spontaneous erections afterwards. But I make the analogy of like getting a hip replacement. Like when you're bone on bone, you can't stand and you're getting injections into your hip and you're doing all that, and then all of a sudden you get the hip replacement. You can run, jump, and ski, but very often it's not a common thing where someone goes, take my hip out, I don't want it anymore. That's really not the way it works. Most people are really happy that they're now back in life and functioning, and in this case, back to intimacy and having normal relationship with their significant other. Mechanical failure is inevitable. It's a 90% success at 10 years. It's inevitable. Someday in its life, if you use this thing, it will break. That's because it's like everything has a mechanical statistic on it. However, removal replacement is not a big deal. And this slide is a little interesting because it says removal and replacement can cause the penis to become shorter, curved, and scarred. I disagree with that. Removal and replacement in a natural setting does not cause that problem. However, if someone did have an infection, for example, and we had to remove and replace it, certainly then there can be issues with fibrosis, getting shorter, curved, or scarred. But in general, when I do removal and replacements, the contrary is the case. I often actually have to add more implant because the penis has had a girth, an expansion over time, a tissue expansion due to the implant being there for so many years, and I end up having to put a larger implant. So that's what usually happens. Pain and infection can occur, but it's very, very limited to the healing process. Infection is less than 1%. And just to make mention that men that are diabetics that are not well controlled potentially have a higher rate of infection. Certainly spinal cord injury patients that do clean intermittent catheterizations and potentially have contaminated urines can have a higher rate of infection. And open sores anywhere in the body would make me cancel the case just for an increased risk for infection. Next slide. So that's all on the different modalities. Certainly for more information, talk to a prosthetic urologist, someone who's more comprehensive, who can offer penile implants as a solution, that is well-versed in all the treatment options as a subspecialty. Certainly if you have more questions, Boston Scientific has a wonderful site called edcure.org. If you want to follow with me, it's really easy to follow with me. I just go to drblick.com. You spell out the word doctor. Spell out the word doctor, drblick.com, and you can follow with me, and I'm happy to sometimes answer questions or make appointments or facilitate your care. That sort of ends this portion of the talk. I know we have I know there's going to be an opportunity now to sort of open up and maybe do a little bit of like a tutorial and just show the products. And I want to just take just a few minutes to do that for you all, just to give you some sense of some stuff. I hope you can see. I really apologize because I'm with one arm, had a shoulder injury skiing, and unfortunately I had surgery on March 17th, so I can't really move this arm very well. But I'll be back in less than 6 weeks. So this is, I'm going to try to change my screen for you a little bit and just see if I can maybe make this become a little bit easier to show. But this is an example of a syringe. I'm going to pull off the back end of it. That shows you the back end of the syringe right here where you have the piston. And then of course you pull this part off and you have the needle. And that's it. It's a very small needle, 1/2 inch, 30 gauge with all the numbers on it like we talked about. And again, 10 means 0.1 cc's, 20 means 0.2 cc's, 30, 0.3, and on we go. Most of the time you want to be at 0.1 to 0.5. If you're using more than 0.5 cc's, then you probably need to go to a stronger concentration. That's all, okay? And certainly you'll get more bang for the buck, no pun intended there. And so back to like how this works, like I would draw back on the syringe. I can't, let me bring it to the camera here. So I can draw back on the syringe. Let me just do it. So I'm going to draw back on the syringe. You can see I've done it. I've drawn the syringe back. I've created a little air there. And then you take your vial and you turn it upside down and you just put this in. Okay, and then you would shoot the air and you'll see that, well, if I did it on the screen, you would see that there were bubbles. And then you can see that you can just pull this back very, very easily and get your dose that you're looking to have. And then that's it. You just pull it out and you're ready. And that's all there is to it. And then you've got your penis. And what we're trying to show people is that the place not to do it, and I'll stand up, it's just easier for me to hold this. Don't do it on the top. Don't do it on the bottom. That's your urethra right there. You want to do it either at the, let's just say this is the, whatever, 3 o'clock, 9 o'clock, right? Let's do it like that, 3 o'clock, 9 o'clock. So you want to be on the lateral side, and you can go up to as high as the 1 o'clock or the 11 o'clock. So sort of coming off at a lateral angle, and you want to be maybe about 1 inch off the base from the penis. And you can alternate sides and move around in this area safely as long as there's no vessel there. So it would be as simple as once you've drawn it up, you'd wipe this area with alcohol, and then you would just simply go 1, 2, 3 and go boom and put it, and then you would inject it. And then once you come out, you put pressure on it. 2 or 3 seconds is all you need and you're done. It is that easy. And then when you're done, you can dispense of your, there should be a container for you to dispense of your needles so that you can dispense of them properly. And that's the injection therapy. Within 10 to 15 minutes, the injection will ensue. And again, I think you'll find it to be it's a very successful modality for patients. So that covers the injection. A little bit about the vacuum device, just as worth talking about. I'll take this apart briefly, but you can see that there's a vacuum portion and there's a suction portion. And this is the manual because you can push on it. And then there's the cylinder that fits over your penis and it just screws in very, very simply. You just go like that and it's in and you're ready. But before you do that, there's a cone. It's hard to do with one hand, but there's a cone that is designed to fit on the top of the, oh, here, take it back, hold on. I'll set up for you. The cone fits on like this, and it fits on like this. Here, let me show it to you. It fits like this. Before you put this little black ring in place, your cone fits on, and this allows you to place your ring, your tension ring on. Let me see if it's could show. I can't really do it with one hand, but you would put lubrication here, and you'd essentially put this over the top and get this to go down to the level of the base, just the top part of the ring here. I mean, just to the top part of the cylinder. So you'd get your constriction ring just around this area, so that when you put this on, to your body, it'll be easy to flick the ring onto the base of your penis. So it's really not very complicated. Again, there's one unit that is clearly a manual option, and then there's also an option that fits on that is a motor. If you hear it, you can hear it. Like it's designed to pull the suction by through an electrical option. And so that's the vacuum device. Again, it works great for patients who aren't going to be easily able to inject themselves or are not well suited for a penile implant or just not responding to pills, this is an option. It can also be a nice tool for penile rehabilitation like we talked about. So that's the vacuum device. And then just a little bit about the penile implant. I might try, this is an interesting unit, but you might be able to see it. What's happening here is there's a pump right inside. You can't see the pump because it's invisible, just like in real life. But if I get the pump and I begin to pump it, you will see it, I'll start to go a real rhythm. So it's a squish, reinflate, squish, reinflate. And what you should start to see is that the penis will start to rise and get more rigid, which it is doing. I don't know if you can see that, but it is. Let's see if I change the angle a little just to give you a sense. So here we go, just pumping. And it gets to be, eventually get to a point where you can't pump it anymore. That's how you know it's full, because you just can't pump it anymore. I tell people to try to over pump it because they can't break it. They're not strong enough. Get the maximum rigidity and you'll end up with a very solid, firm, hard erection. When you're ready to release, all you do is hit the button and it will go down. And you just push, actually squeeze it if you wish to bring it more fully to soft, and it'll just all go right to soft. And that's sort of the different modalities that we have here. So I think that covers, a lot. It's a lot of information in a short time. I think we're at a place now where we can probably go to take some questions.
All right. Yeah, so we're actually at 7:30. I know that's the designed end time for the event, but if you've got a few extra minutes, we'll go through a handful of questions.
Happy to stay as long as anybody wants.
Okay, great. Awesome. So let's jump into this then. First question here is around injections. Why doesn't the injection work all the time? Is it something that I'm doing wrong? How can I correct it? Maybe 2 out of 10 injections work.
So one, making sure that the product is, this may be maybe kind of obvious, but you certainly don't want to use medicine that's too old. Make sure it's a good batch. Number 2, making sure that you are putting the needle far enough into the corpora cavernosa that you are getting the proper depth, so that, because it can be a little bit scary. I don't know if some people are a little bit hesitant to do the injection. And if that's the case, they may be a little hesitant and not getting far enough in when they do the injection. And then the third, it just may need to be a slightly higher concentration to get it to be more reliable. That would be my answers.
All right, next question here. I find trimix injections painful. Is it poor technique, or should I look into intraurethral gels?
No, I think we covered that in today's talk. It is possible that the L-prostadil is causing, maybe I'm misunderstanding the question. If is it painful when you give the injection, do you cause pain, or is it just the injection itself is painful? If it's the injection itself, we can certainly go to other modalities. That's simple. There are many other modalities that we presented today besides an injection. If we're talking about needle pain, if we're talking about pain from the medication within the shaft of the penis, we can drop off the prostaglandin E1 and offer Bimix or low concentration L-prostadil to make a more successful option. So that's something you just talk about with your physician for sure. There are other modalities.
All right. Once you begin the injections, will you be able to go back to natural erections, or will you need the medication forever?
No, I think you can use injections safely, and if you still have normal blood flow to a certain degree, it would be okay to go back to normal. I have some patients that have a milder degree of ED, and they can get erections probably without it, but they just want to enhance their success, and so they use the injections pretty safely, and they have normal erections, and they use them sometimes and don't use it other times. Pretty flexible.
All right. When using injections, I immediately get a blister type bump on my penis. What am I doing wrong?
I would think that probably from the time that you're pulling out the needle to the point that you're putting pressure, there may be a delay there, and some little bit of blood might be coming back, or you're possibly hitting a small blood vessel in the area, and that's what's creating that bump. So you just have to A, look and make sure there's no vessels in the area, try using a different site. B, make sure that once that needle comes out, boom, you get a quick pressure on it, and that might minimize that effect.
All right. Next question here. Injections worked well, but left scar tissue lumps in the shaft area of my penis. Can these be removed or broken up, or will they go away on their own?
If you're forming scar tissue in your penis, they are hard. They can be broken up. We have techniques to inject different kinds of medicine into those to break them up. It's called Xiaflex. They're not going to go, they don't always go away on their own. They can go away on their own on the order of 12 to 15% of the time. So it's something that if you're seeing scars from these injections, I would stop doing the injections, give yourself some time, see what happens over a 3 to 6 month period. And if those scars don't go away, then there are methods to try to help dissolve those in office, using most likely Xiaflex if that's the case. But yeah, if you're someone prone to having scar tissue there, I would probably recommend a different modality.
All right, next question here. I've been using ICI for the last 6 months. Are there long-term consequences to using Trimix 1 to 2 times per week?
The only long-term, I think I kind of mentioned this in the talk, long-term is pretty safe. Over time, I think what we find, number one, is it will become less effective and you'll need higher volumes and higher concentrations respectively. Number two, there's going to be eventually over time potential development for some scar tissue that may build up internally that accounts for this phenomena. A very small percentage of patients can develop scars or this phenomena of Peyronie's disease like we were just talking about. Most patients don't develop those things and do just fine.
All right. I take injections and can have penetrative sex, but orgasms are very difficult to achieve. What can I do to achieve an orgasm?
So a delayed orgasm is almost a whole different topic. It's a much broader conversation to look at why someone doesn't have an orgasm. I don't think it has a lot to do with the actual injection itself. It's not the modality. It may be a whole host of different things. There can be psychological issues that are at play that make someone have a delayed orgasm. There could be medications that are at play that might be involved that make it harder for you to have an orgasm. So it can be hormonal. Sometimes people have low testosterone. So it's worth like a real more significant conversation with your urologist or primary care or whoever you're working with to learn more about why you might be having that. I don't think it has anything to do with the injection.
All right, moving on to some implant questions. Does your libido change when you get an implant?
No, it doesn't.
All right, next one here. I'm a cyclist. How would an implant affect my ability to continue riding my bike?
You're okay to ride your bike. It won't affect your ability to ride your bike. You're safe to do it. No issues whatsoever.
Okay. Next question here. Are implants suitable for patients who have a bladder sling installed?
Yeah, you can have in fact, we often do them at the same time. So you can have I might not call it a bladder sling, I'll call it a urethral sling. And the sling is often placed, down below through a perineal incision. And we can put that into position and fix the male leakage problem, often found after, let's say, prostate cancer surgery. And at the exact same time, go then put the legs down out of stirrups and do a penile implant at the exact same time. So no issues whatsoever. We do them together all the time.
All right. Next question here. How old is too old to get implant surgery?
Well, let's say it this way. The oldest I ever did was 89. So it really comes down to your specific situation, how healthy you are, how well is your heart to tolerate a very basic, minimally invasive procedure. If you're healthy enough, we can do it almost at any age. I know that for a fact there have been people who've done in their 90s. So there's really no restriction on age. It's very circumstantial and very specific to people's needs.
Wow, good for those people in their 90s.
Imagine.
Yeah.
Yeah, I wish, God bless them.
Yeah, hopefully we're all that lucky. Next question here. Are there penile implants that can make your penis length longer?
So the answer is yes. There are different products on the market, but within Boston Scientific's armamentarium, they have a product that expands in length and girth. And so depending on the size of your penis, we often will utilize that in order to enhance long-term success because there is a tissue expansive effect to the penile implant. And so if you're somebody who is slightly on the shorter side and does not have Peyronie's disease, we often use this LGX product, which expands in length and girth. If you're someone who has a longer penis or happens to have Peyronie's disease or curvature, we tend to use something called the CX cylinder because it's more rigid and will help with the straightening of the penis better, although it doesn't have the exact, penile lengthening property to it. But so the answer is yes, we have that product. It can be utilized in really all lengths, but as we go into longer lengths, that product can sometimes lose some axial rigidity. And so I tend to use the more rigid cylinder for my longer penises and for Peyronie's disease, and I use this LGX expansive cylinder for my slightly shorter penises. And that's my sort of algorithm, but that's a little bit of a long-winded answer to that question. But yes, that product exists.
Gotcha. And speaking of Peyronie's disease, we had a question about that regarding implants. Will having both Peyronie's disease and scar tissue from injections create complications in prosthetic implant surgery?
Well, I'm sorry, for some reason I didn't, could you repeat that?
Sure. So will having Peyronie's disease from injections create complications in prosthetic implant surgery?
Okay, so if you've had a penile implant, you can inject your penis. If I heard that right.
No.
Did I hear that right? Like, in other words, if you could certainly be someone who's an injector and develop scarring that causes curvature, and then the penile implant is the treatment of choice to straighten that curvature. But if you're someone who has a penile implant for erectile dysfunction, never again would you need to inject your penis. You would injure the device and cause it to deflate. So
yeah,
so
absolutely. They're just asking if there would be any extra complications if you had Peyronie's disease, if you were considering an implant.
I see. Yeah, and if you're considering an implant with Peyronie's, there won't be extra complications. It can make the surgery sometimes more challenging. It can sometimes require extra correctional surgery, meaning that once the implant is in, if the curvature is so severe that we are not having an adequate result, we can sometimes straighten the penis with extra correctional surgeries, although those are kind of rare. We don't do them all the time. But I will tell you this, penile implant straightens the penis for Peyronie's disease beautifully. So like if you have 30, 40 degrees curvature, you may come out straight after the penile implant, just because the implant has that tissue expansive property and rigidity to it that it straightens the penis all on its own. So the treatment of choice for erectile dysfunction and Peyronie's disease together is a penile implant.
All right. Last question here around implants. Do implants help with climacturia after radical prostatectomy?
So climacturia, for those who might not know, means when you have an orgasm, you might leak urine. And so there are techniques for when you place a penile implant, if you've got very mild incontinence, instead of doing a male sling at the same time, there's a little technique called a mini jupette technique, which you do the penile implant through a scrotal approach and apply a little band between the two cylinders. And when the implant inflates, it gets rid of the climacturia. So it's possible to fix the climacturia with a penile implant in place. It's possible to know that you have it and potentially do a procedure up front that might minimize that complication postoperatively. Certainly if we're doing a male sling and a penile implant for incontinence, that often gets rid of it as well. But the answer is that we can treat that climacturia in multiple ways depending on your situation.
All right, we'll ask a few more questions here and then we'll go ahead and wrap it up. Next question. I'm only 20 years old. The pills do not work for me. I cannot use injections at my age without being laughed at, and I feel like I'm too young for an implant. What should I do?
So, I can't, I mean, it's obviously, I'm getting this information without having all the details of this person. The first thing that comes into my mind for a 20-year-old is that there's a psychological issue. And we often in our office do something called duplex Doppler ultrasonography. It's a way where we inject you. We actually do the injection in the office, facilitate blood flow, make measurements, and can decide whether there really is a blood flow problem or not. And that may be really helpful in addition to also checking your testosterone and a few other labs that would be helpful in understanding if there's an organic issue going on. If there isn't an obvious organic issue, sexual therapists can be extremely helpful in this area. And I can't tell you enough. My wife is a therapist and she does a lot of the sexual therapy in our practice. And over all these years of being in private practice, I've had the opportunity to see how patients are treated in this area. And I can tell you that a very high percentage of these patients will do well without needing a single pill or an injection or an implant or anything, with a good therapist who understands the issues. And to be honest with you, it's the sexual stuff is actually a barometer for all the rest of it. So it's not just sexual therapy, it would be comprehensive therapy. It really gets into every element of your life. And I've just seen wonderful stories of people changing everything just by having good therapy. So I recommend the testing, good both laboratory and duplex Doppler ultrasonography, and depending on the results of that, I might suggest therapy as an option.
All right, next question here. I'm using injectables, but my erection immediately goes away when I lay down. What's going on?
So you might be someone who has something called a venous leak, possibly. And so interestingly, we can identify that with duplex Doppler ultrasonography. Again, we can give an injection in the office, make measurements, and sometimes we can determine that you have awesome blood flow, but the problem is that your veins are leaking. And sometimes that happens just with age, naturally. Other times it happens as a part of a disease entity. People have had it happen after their prostatectomies. They have it happen after radiation. It happens with Peyronie's disease and the curvature of the penis. It can happen with other chronic illnesses. People have been treated with chemo and radiation. So it's really important. It's just a hypothesis that could be what's going on. And so it may be worth a further level of testing to understand better what's going on. Let me add one more thought. You know, if for some reason you don't have access to that, venous leakers sometimes do well with constriction rings, and sometimes the vacuum device can be helpful. So you can pull blood in, maintain the erection, and put the constriction ring from that on, and that can sometimes maintain the erection in any position. So that may be an option for you to play with either constriction rings independently or using the vacuum device as a tool as well. But that may be another option if you're not easily able to gain access to a more sophisticated level of testing.
All right, 2 more questions and we'll go ahead and wrap it up here. With the injections, what is the treatment if the erection lasts too long? Is Sudafed a suitable home remedy? And how long is too long?
Yeah, so like I mentioned in the talk, we never really want to have anybody have an erection that lasts more than 4 to 6 hours, because again, that's trapping blood in the penis. That becomes low oxygen tension, and it can cause scarring inside and cause irreversible damage. Sudafed is not an unreasonable thing to try. The highest dose that you can get from the from your local pharmacy, Walgreens, is fine to start. And if that doesn't work within a reasonable amount of time, to be fair, you really then have to move into this thing called phenylephrine. Phenylephrine is a strong vasoactive agent that will cause vasoconstriction that will help reverse the whole process. In fact, it should approach 100% success if it's done in the right time frame. We can either self-prescribe it we can prescribe it to you if you feel like you're vulnerable to this, or you can run to an ER urgent care, and they are skilled to give you the proper dosing and injection accordingly. Certainly, I tell my patients if it's during office hours to come straight to my office, because we can do it in the office as well. So phenylephrine is the best choice. Sudafed usually doesn't work, to be honest, but there's no harm in trying it for a short period of time. But you don't want to like I tell people, after 2 hours, if their erection is rock solid, that's when you're trying Sudafed, that's when you're trying to ejaculate, cold shower. But certainly by 3 hours, you've got to get yourself into some kind of be on your way to some form of treatment. Otherwise, you're going to end up lasting too long, and get into trouble. Okay.
Absolutely. All right, and the last question here, can I use Viagra or Cialis in combination with injections, VEDs, or intraurethral gels?
So we can. The answer is yes. It's possible to combine modalities. I would recommend doing that in the care of a urologist who's a little more skilled with working with these medicines and has the anecdotes for priapism. But the answer is yes, we can put them together. It would not be uncommon for me to let's say use Viagra and do an injection at a low dose. If someone's having, let's say, doing okay but not good enough, and they just want to enhance themselves, we might add the injection to it. But under very controlled circumstances, we would moderate the doses accordingly and make sure it's a very controlled environment so that nothing bad could happen. I wouldn't just do it on your own. I'd probably talk about it with your urologist, And so there is an opportunity to interplay these different agents for creating better results.
All right. With that, I'd like to thank Dr. Blick for taking the time to present today. And we'd also like to thank everyone listening in for attending this MinMD Real Talk webinar. We hope it was informative and that you will join us again in the future. If you'd like to learn more, you have a few options here. There are more resources in the Resource Center on minmd.com. Visit this page to view instructional videos, guides, expert articles, and more. You can also call MinMD at 857-233-5837 or log into the password-protected, secure MinMD portal to schedule an appointment with a MinMD clinical case manager. If you don't have a specialist for your sexual urinary tract health, MinMD has a new physician finder service. Go to minmd.com and click Find a Physician to get started. And finally, you can learn more about penile implants and insurance coverage by visiting edcure.org. We'll also be sending a follow-up email with references to helpful resources and links to each after the event. I'd like to thank everyone again for attending today's webinar. We'll see you at the next one.
Thank you, everybody.